Start recording. Okay, so here is the math. So again, it's always those bolus questions. They're getting a bolus of an anti-seizure medication. The dose is 1 gram in 50 milliliters to infuse over 30 minutes. How fast in milliliters per hour? So it's just 50 milliliters is what's the important thing over 30 minutes. So that's just 100 milliliters an hour. The patient is to receive 500 milliliters of normal saline over 4 hours, and the IV tubing has a drop factor of 15. How many drops per minute will that patient receive? So we are giving 500 milliliters over 4 hours. 500 milliliters over 4 hours. 1 hour equals 60 minutes. 1 milliliter equals 15 drops. I think I remember that what it said. Yes. Ooh, Lillian. Yeah. So there's the equation. If we add that, it's 500 times 15, which is 7,500 divided by 4 divided by 60 is 31.25, which if we round to a whole number, obviously because we can't calculate a fourth of a drop, would be 31 drops per minute. What the hell, Schultz? Okay. And then the last one, patients to get 200 milligrams of phenytoin 3 times per day. Each phenytoin pill is 100 milligrams. How many pills will the patient need per month? If the month is 30 days. So there's 3 doses of 200 milligrams, so we know that we need, and the pills are only 100 milligrams each, so we need 6 per day, and then 6 times 30 is 180, so hopefully that went okay for everybody. Any questions about the math at all? You know there's always going to be math questions where you have to calculate if a little mini bag is mixed with a certain amount of medication and a volume. That's always going to be a question. No, love the math. Yeah, usually that's a source of points. Sometimes it doesn't always work as you want it to, but I know usually people ask for more math questions because that can sometimes help a little bit. There will be math on the cumulative final, and the ATI exam too might have a math question or two. So when you're doing the ATI, be sure you look really closely on what their rules for rounding is so that you don't make a mistake on the ATI. And that I know some people get a math block. And then I believe that I loaded the wrong thing just because this day is falling apart. This should say where I was seizure medication blank form, but it is the same thing we did before, which is not correct. It should be this, which is what I will load for you guys with the answers so you can see. But essentially it's a way for you to organize which ones have the skin conditions, which one is fluid retention, because these types of adverse effects are usually the things that end up in test questions. And then this last part, administration rules, you know that they all need to be taken with food to avoid stomach upset. Some of them you can. There's one that you are, which is valproic acid, which is not common, that you actually can open up the capsule. So just a way to organize that information. So I will fix that so you can actually see the right form. So that might help you study a little bit for the traditional medications. Let me just check while we're all here that the study guide is correct. Nope. I gotta fix that study guide, so don't go by it yet, because it has some respiratory medications on it, which we are not doing now. So this study guide needs to be fixed too, before you copy that and think that's the medication. So don't look at that. And we'll get rid of this because, oops, because nothing is going right today. Okay, but we will do behavioral health medications, and that'll be the last part that we need in order to take the exam next class. So this group of slides goes through different mental health disorders and treatments that can be used for those mental health disorders. So there's something to keep in mind is there's always a range of symptoms. If someone has anxiety, there's a range of symptoms they could have. To just every now and again isn't something that they need anything for, to this is really bad, it's interfering with my life, I need to take medication, to all the way to the extreme where it causes a condition called psychosis, where the patient really does start to separate from reality. You know, there's a psychosis, there's a psychosis for depression too, that you start with some feelings of sadness all the way to the middle point where you need medication because the sadness is interfering with your life, to psychosis where the depression is really caused the person to make a break with reality. So when people started treating mental health disorders, the first ones for treatment were anxiety. And anxiety was treated similar to insomnia, thinking that the person just has a very overactive center in the brain that's in charge of alertness and perception of danger. So if we can quiet that area, then the person will be able to sleep and be less anxious. But the feelings about treating anxiety have changed. Instead of just trying to quiet or like slow down the brain's function, it's usually seen as an imbalance of neurotransmitters, just like depression is. And so treatment for anxiety has changed to incorporate the use of antidepressants as the main treatment. But when we talk about anxiety first, we'll talk about the first treatments, which are really just to slow things down. So anxiety, the definition is apprehension, uneasiness, anticipating danger, but you can't pick what the danger is. So you feel like revved up, like something bad is going to happen, except that there isn't any danger, or what you feel is dangerous is really, your feelings are way more than is necessary for that feeling of danger. There are several types of anxiety. Generalized anxiety disorder, panic disorder and phobias, obsessive compulsive disorder, post-traumatic stress disorder have anxiety components to them. And most people with anxiety, all of those types of anxiety, may have a component of insomnia as part of their symptoms. So insomnia is an inability to fall asleep or remain asleep, or a combination of both. And obviously important because sleep allows for body repair as well as processing new information, which is why everybody always says to people that studying all night and staying awake all night the night before an exam isn't helpful, because that's not how your brain works. If you want to be sure to learn something, you would practice information and make your brain focus on it and then get a good night's sleep, because that's how your brain lays down memory. So types of insomnia could be short-term, related to stress, long-term insomnia, meaning the patient frequently has nights where they can't fall asleep or they wake up a lot, or rebound insomnia, which means the patient has been taking medication for insomnia, which has helped, and then they decide to stop taking the medicine and they develop a rebound insomnia, meaning they again have those symptoms because they stopped taking the medication. And most people will, or most providers will say that it's really best to avoid medication treatment for insomnia because those medicines become, I don't want to say addictive, it's just that you can't sleep, your body becomes used to them. You have a physiologic dependence on them, is the word I was looking for. You can't sleep without them. It's better to try to change sleep behaviors, like avoid caffeine, only use your bed for sleeping, not being on your phone with bright lights in your face before you try to go to bed. You're supposed to slow down activity before sleep time. So we did talk about benzodiazepams or benzodiazepines as a way to help, but with very strong doses and depending on the medication, to stop status epilepticus, or as part of general anesthesia or conscious sedation. You can use medications like that for anxiety and insomnia, except they can become habit forming and the person can become physically dependent to them. There are other medications for sleep that are in the non-benzodiazepine, non-barbiturate category, that their own separate category. Those are not meant to treat anxiety, they're meant to treat insomnia. So if we're talking about a benzodiazepine that is supposed to help with anxiety or sleep, our prototype is Lorazepam, which is Ativan. There are many benzodiazepines. They all end with PAM. So we talked about Medalazam, which is Versed, and diazepam, which is Valium, when we're talking about status epilepticus and conscious sedation. Lorazepam is Ativan, clorazepam is Klonopin. There are others. These, again, are working just like the ones we talked about before. They are allowing chloride to enter the cell to become more negative, so it's harder for that cell to depolarize or accept electrical activity. So this can be given PO before sleep or during an acute anxiety attack, or it can be given IV, but just like we talked about before, we worry about respiratory depression. And so if someone is given the medication IV, then their respiratory rate has to be monitored every 5 to 15 minutes. So be sure you have that in your mind. And we know that this medication will cause some degree of drowsiness and sedation. That might be why we're giving it, if we're trying to help somebody sleep. Sometimes in the hospital, people will use Lorazepam for confusion and restlessness and agitation. But that does require extra monitoring of the patient, because they could have respiratory depression as well as hypotension, changes in their orientation and forgetfulness. So it can go the other way. especially when you're using it in the hospital in order to decrease agitation in a patient. We shouldn't use with glaucoma or impaired brain function, because that will make those conditions worse. If the patient has liver disease, they'll be less able to metabolize the medication, and there is dependence. So it's not something, if someone uses lorazepam or a benzodiazepine daily, you can't just stop that medication. You have to wean them from it over a couple of weeks, or they'll go through withdrawal. The other medications, the non-benzodiazepine, non-barbiturate treatments of insomnia, include things like zolpidem, which is Ambien. So zolpidem is supposed to only be used for short-term insomnia management, 7 to 10 days, and it usually works rapidly, so it should be given immediately before, it can be, before the person goes to sleep. So it is very effective. However, it is one of those medicines that causes rebound insomnia. So if the person takes it every single day, and then the prescription is up and they try to sleep without it, the person will have insomnia. It's best to use it very, very intermittently and sparingly. And there are neuropsychiatric effects. So there's a black box warning on zolpidem now, because people have sleepwalking, sleep eating, where people have eaten a ton, sleep driving, where they've driven not being conscious of where they were even going. Somebody used zolpidem as an excuse to get out of a murder case, saying that they were in the midst of zolpidem's effects when they killed their partner. So there is, it is not the safest medication necessarily. Yeah, it's not. Some people have a lot of effects from it. Long ago, I used it once, and I thought it was very effective the first 2 days. Like, I was like, wow, I better go to bed before I fall over. But it didn't last long. Once I got to the third or fourth day, it really didn't help me anymore. And you might notice there's a lot of over-the-counter medications that can also be used to help with sleep. Some people use Benadryl or diphenhydramine for sleep, which is an antihistamine, which we'll talk about when we talk about respiratory medications. And you may have seen over-the-counter melatonin, which is a natural occurring hormone in our brain that helps to regulate our sleep and our circadian rhythms. But the over-the-counter melatonin doesn't work forever either. You can burn out on that, meaning if you take it religiously for 3 to 6 months, it might not have the same effect for you. All right, so now we're getting to our next mental health condition, and that is depression. So it's obviously beyond just usual sadness that people might have now and again, or situational sadness related to some kind of loss or grief. In order to be diagnosed with depression, you have to have 5 of these following symptoms for at least 2 weeks. So you have to have enough that it's starting to interfere with your life. And there, of course, is different types of treatment, having a therapist, doing talk therapy, and then medication, or doing both. And the medication itself is based on the fact that there are neurotransmitters in the brain that do contribute to mood in our body. So dopamine is one of them. Contributes to alertness and some motivation and memory. Norepinephrine, which is important for concentration, memory, determination, and then serotonin, which is really pleasure, relaxation. So all of them together, balanced in balanced proportions, should contribute to a balanced mood and decrease depression. So the medication theory of depression management is that if someone has depression that's not related to a situation, that they just are depressed, then it's probably related to an imbalance of these neurotransmitters, and the medications are supposed to balance those neurotransmitters in order to help the person's mood. So, different medications have come out that are trying to balance these neurotransmitters. The first group one of the groups to come out that we'll talk about are tricyclic antidepressants. So this is a medication taken by mouth. Our prototype medicine is Imipramine, but you may have seen other tricyclic antidepressants, or you might see other tricyclic antidepressants prescribed for other things. Like amitriptyline is sometimes prescribed for sleep, it's sometimes prescribed for chronic migraine. So you might see it, so is doxepin, so you might see these medications used for other things, but they are antidepressants. They're called tricyclic because they are the way their chemical structure has like 3 circles in it, that's why they're called that. But what they're supposed to do is affect serotonin and norepinephrine at the same time. They're supposed to block reuptake. So we've talked about reuptake. Here's our nerve, and then we have the next nerve, because this is in the brain, the central nervous system, and there's receptors, and this is the synapse, and there's the packaged neurotransmitter, and the action potential goes down, and that causes release of the neurotransmitter. And in this case, it would be serotonin or norepinephrine, which we know contribute to mood and concentration. And if the person has a depletion of norepinephrine or serotonin because of some other issue, then we can try to increase the presence of norepinephrine and serotonin by blocking the recycling of those neurotransmitters. So there are ways to get rid of neurotransmitters in the synapse. One of them was those enzymes. So we talked about MAOB, which is the enzyme that breaks down dopamine, and we talked about cholinesterase, which is the enzyme that breaks down acetylcholine. That's one way to keep neurotransmitters in the synapse, is to block those enzymes. The other way that this synapse gets cleared of neurotransmitter is some of the neurotransmitter goes back inside the neuron to be repackaged. That's called reuptake. If we block reuptake, then more neurotransmitter stays in the synapse and it's able to interact with the next nerve. And that's what these medications are doing. We're trying to keep norepinephrine and serotonin in the synapse longer. It actually also affects acetylcholine in nerves as well. It wasn't meant to. It was only supposed to affect the activity of norepinephrine and serotonin, but it also can cause anticholinergic side effects because of what it does to acetylcholine too. So we meant it to increase our happiness and concentration, but then we ended up with anticholinergic side effects. And then we have to remember what anticholinergic side effects are, because those are, anticholinergic means we're blocking acetylcholine. So it's similar to the sympathetic nervous system. So that means they might have pupil dilation, they might have an increase in heart rate, increase in blood pressure, they might have dry mouth, difficulty urinating, difficulty passing stool. So they might have some of those side effects that we consider anticholinergic. They can have diaphoresis, which is being sweaty, especially if they're diabetic. And anyone who starts an antidepressant, so this is for all antidepressants, is at increased risk of suicidal ideation, especially when they first start. My theory is that it's easier to affect the neurotransmitter like norepinephrine that helps with concentration and motivation than it is to affect the serotonin right away, which affects mood, so that they end up having more ability to do things before they're truly start to see it impact on their mood itself. So anyone starting an antidepressant, especially an adolescent, is at increased risk for suicidal ideation. So they need to be watched carefully when they're first starting. And especially with imipramine, because you can use tricyclic antidepressants to commit suicide. They, if taken in large quantities, will cause dangerous arrhythmias and MI. So they definitely, the person who is on tricyclic antidepressants, especially in the beginning, has to be watched to be sure they're not increasing suicidal thoughts. Other things you have to worry about are glaucoma. It can make glaucoma worse. And if the patient has kidney or liver impairment, then the dose has to be adjusted or they can't take the medicine, because that could decrease excretion and metabolism of the medication and increase the risk of heart symptoms. So that's the tricyclics. The ones that people are more familiar with usually are the serotonin reuptake inhibitors. So the thought was, if we focus more on the serotonin, kind of the happy neurotransmitter, then maybe we'll improve symptoms and have less side effects. And then we won't have to worry about the person's heart as much as we were worrying about with the tricyclics. So this was the innovation, just try to target serotonin in the brain, stop reuptake of serotonin so we can increase serotonin. The first one that was developed is fluoxetine, which is Prozac. The one that's in our textbook, the one that will be our prototype, is Sertraline, which is Zoloft. Prozac was first, then Paxil, then Zoloft, then Celexa, then Lexapro. Each time there's been a new SSRI, or selective serotonin reuptake inhibitor. The goal was to make it that much more selective, so it's not affecting other serotonin receptors in the body. So sertraline is an oral medication, which could be a pill or a liquid. If it's a liquid, it should be mixed with another liquid. You shouldn't just take it plain. And it can take a while for onset of action. It can take 2 to 4 weeks, so it's difficult to predict the half-life. So people will start taking the medication but not feel the effects of it necessarily for up to a month. So you have to be sure that they're aware of that so they don't give up on it too soon. We know that when patients are taking medications that have very long half-lives, that sometimes we give a loading dose to get around that long half-life, like we've done with antibiotics, but we can't do that with antidepressants because we can't give a loading dose. We'll end up giving too much at one time and could cause a problem. Some side effects that can occur, always, I guess this is more of an adverse effect, always a risk of increased suicidal thoughts, suicidal ideation, especially when first starting the medication, especially in adolescence. And then some people have dizziness and somnolence, and some people are agitated and have insomnia. So it depends on how the person reacts to it. If it makes them more sleepy, then it's probably best to take it before bed. If it makes them more awake, then it's best to take it in the morning. Headache and potential change or potential sexual dysfunction with decreased libido or impotence in men. So be sure that people understand that. The more selective serotonin inhibitors have less sexual dysfunction and usually less GI effects too, because some people have problems with appetite as well. And then the last group of medications for depression, and this is where we'll take our break, are MAO inhibitors. So Sertraline was an MAO-B inhibitor because it inhibited the enzyme that breaks down dopamine in the neurotransmitter. This is a different MAO, monoamine oxidase inhibitor, that is operating, which decreases the breakdown of norepinephrine in the synapse. So we are stopping norepinephrine from being broken down in the synapse. If norepinephrine stays in the synapse longer, we might have an improvement of symptoms. So this medication isn't used as often for depression as it used to be. Sometimes you'll see it prescribed with people whose depression isn't responding to other antidepressants, or if someone's been on an antidepressant for a really long time, because these were used more in the past, you might see it. You cannot use it with the tricyclic antidepressants or selective serotonin reuptake antidepressants, as the patient will develop fever and seizures. So you might notice in lots of commercials for drugs, they'll say not to be taken with MAOIs. That's what there's always, don't take it with MAOI in the commercial for drugs. There's a lot of drug interactions with this. And it cannot be used if the person has severe cardiovascular disease like angina, hypertension, or they've had a stroke before, or pheochromocytoma, which is an increase in release of norepinephrine from a tumor, because these people are already at risk of having elevated blood pressure, which is one of the things that can happen with MAOIs. If the person has liver or renal impairment, then you have to be careful about the dosing because there's increased risk of toxicity. You have to avoid caffeine because that can also increase toxicity, and tyramine foods. So tyramine is broken down tyramine in food is broken down by MAO in the intestine. So if you ingest tyramine foods, you'll have a rapid increase in norepinephrine because you're not able to break it down, leading to hypertensive crisis. And the patient, some of the symptoms they'll have is headache, stiff neck, sweating, nausea, flushing, but the blood pressure can get so high that they could have a stroke or a heart attack. And these are, again, those tyramine foods: cured meats, wine, chocolate, aged cheese, things like that. So other medications that are sometimes used for depression, bupropion is Wellbutrin, duloxetine or venlafaxine, Cymbalta and Effexor also are affecting norepinephrine. Those are some other medications that are used for depression, but those won't be on the exam. So it's almost 1:45, so we'll take a break before we start bipolar. So we'll take a break till 1:55 and then finish up with behavioral health medication. Okay, so we'll finish up these medications. For the study guide, I just fixed it. The correct study guide is now on our Blackboard page, which covers, the migraine medication is the triptans, and then the medications that we're talking about right now. So we left off with bipolar disorder. Bipolar disorder means the patient is having periods of depression, which we just spoke about, those symptoms of depression, intermixed or followed by periods of mania, which is elevated activity and irritability. Some of the symptoms of mania are listed below here. Very talkative, less need of sleep, very goal-directed, excessive involvement in pleasurable activities. So during mania, people can engage in high-risk sexual behavior, can engage in drug use, can spend a ton of money, and grandiosity, thinking that they are better than other people, that they are bulletproof, that they're going to be just fine no matter what kind of decisions they make during this time. And during periods of mania, the patient can actually feel really good. So they are not going to necessarily notice that there's a problem, except that they are probably in the midst of destroying their life. They're going to have issues in terms of finances, and he actually does have bipolar disorder and mental health disorders. And the sad thing about Kanye is he stopped taking his medication, which is why that he kind of acts like he does right now, because he needs it. But that's what happens. And for normal people that don't have a ton of money and other things like that, this is very difficult disorder, because during their periods of mania, they may not realize how much they are really destroying things until they reach their low major depression, and then they've lost their job or whatever partner they have, and they've lost tons of money, and now they're stuck with addictions and stuff like that. So the key to treatment of bipolar disorder is really leveling off the mood. And so there are mood stabilizers trying to keep them in. We don't want to just take away the mania, because then they're left with depression, and certainly they're not going to be compliant with that medication. We don't want to just treat depression, because the mania is going to really contribute to their life success. So the first medication used for mood stabilization is lithium. Not as many people with bipolar disorder take lithium. A lot of people with bipolar now take seizure medications that change electrical activity in their brain, and that seems to be very effective. There are still people that take lithium, however, and it's still on all of nursing exams, so we still have to learn it. It's one of those medications that has a very narrow therapeutic range. Right there is listed 0.6 to 1.5 milliequivalents per milliliter. It is a salt, actually. That's why you see the milliequivalents, and it has a relationship with sodium. So if sodium is low, then the lithium level will be high. And if the sodium is high, the lithium level could be low. They do have a opposite interaction with each other. So if the lithium level is toxic, which generally occurs when the sodium is low, the patient can die, because it can lead to profound hypotension. So anything that could lower the patient's sodium, and it's usually some other illness, maybe they got really, really dehydrated and they lost sodium and water, or they were really, really sick and got dehydrated that way. Anything like that could definitely lead to lithium toxicity without the patient intending. It wasn't like they took too much on purpose. It was that imbalance of sodium. So we have to be careful with people on lithium. Their level gets checked. If they're feeling sick at all, they need to let their provider know, because their medication might need to be adjusted or held. So we do have to be careful with that. Otherwise, like I said, they might be on other anti-seizure type medications or even antipsychotic medications. Our next disorder, as we leave bipolar, is attention deficit hyperactivity disorder, ADHD. So you do have to remember, just like we were talking about with depression and anxiety, is that there is a range of presentation of every disease, especially for mental health. So attention deficit hyperactivity disorder on the low end is kind of normal. Some of these things are normal child things. They are distractible. They don't always want to follow commands. They might have an inability to sit still. I mean, that's just normal being a toddler or being a young school-age child. It's when these behaviors interfere with the ability to take in new information or perform at school or work, whichever, that you can consider treating it with medication. There's other things you can do too to try to focus your behaviors. There's other things like, sitting in front of the class, sitting on like one of those gel seats where you're constantly able to move around, using different fidget toys so that you can keep moving. But if it gets to a certain point, you could put the person on medication. And typically this is a disorder that's diagnosed in childhood, although there are people as adults who are diagnosed. But the patient should not be placed on medication unless they've had the testing, the neuropsychiatric testing, to show that they do have this disorder. 'Cause sometimes, especially in children, that is the diagnostic criteria, is they went through neuropsychiatric testing, which is a 6-hour day of tests, to see if they truly have issues receiving information. So very distractible, inability to focus, can't remember, inability to sit still, impulsive behaviors. If the person is diagnosed, yes, that is. So Crystal is mentioning, if you don't see it in the chat, that they didn't test before diagnosing him. That is, depends on the pediatrician, but it is best practice to actually do the testing, because you'll find that there's again a range of scores, and it's possible that different interventions like non-pharmacologic interventions could also be helpful in deciding whether or not to medicate the child, because medication in and of itself is not without its own problems. So, you're sharing about your son. My daughter, when she was in 2nd grade, I was told that maybe she had attention deficit disorder by her teacher. She wasn't hyperactive, but she was not paying attention. And we took her to have testing, and she did have mild ADHD, kind of what they said was on the border of medicine, of needing medicine. And we decided to do like behavior modification stuff to try to help her keep her attention rather than give her medication, especially because she's already super thin. Because that's the issue with those medications, is they're stimulants and they can affect the growth of the child. So you could ask for that, Crystal. It's, you could ask for it to be done. Yeah, I agree. It's done like my pediatrician is through Children's Hospital, but you have to make an appointment with like a separate provider to do the testing. It was helpful. So ADHD are usually central nervous system stimulants versus non-stimulants. The one we're going to talk about is the first one, which is methylphenidate. Methylphenidate, which is Ritalin. Adderall and Vyvanse are also CNS stimulant medications for ADHD that are typically given when children get older. I've seen Adderall and Vyvanse used more in adult populations, but that can be either. Strattera is a non-CNS stimulant medication that can be used for adult onset ADHD. Um, it seems counterintuitive to me, like why would you give somebody with hyperactivity and attention deficit a stimulant? But it seems that the stimulant actually focuses their attention. So yes, it's a stimulant, but it makes it easier for them. It sort of like straightens out the circuits instead of going every which way. We're just going to focus on one thing, which is why it's helpful for people that have it. So it heightens alertness, but it is a stimulant. So you have risk of nervousness, insomnia, hypertension potentially, and it could lead to liver toxicity. So again, just a friendly reminder about the symptoms of liver toxicity, which is, abdominal pain, ascites, yellowing of the skin, light stool, dark urine, changes in blood tests like ALT or AST and bilirubin. And it can make it difficult for the child to gain weight. So usually when the patient is first started on methylphenidate, which is not on here, so be sure you have it written down, is they need to see their provider more short term in the beginning to check their weight, so be sure you add that, and to check their blood pressure to be sure that when they've started this medication it hasn't affected that. It can suppress the appetite, and so that can be the issue with weight. So the recommendation, especially if the child is having difficulty eating and they're losing weight, but for all children, is that they should have drug holidays. So the reason to use the medication is to make them more successful in situations that are harder to maintain attention, like school. So it can be helpful to give them a holiday, when school is not in session or during the summer, so that they have time to catch up with growth if needed. And then, we're going a lot faster than I thought. So this day is just not my best teacher planning day, that's for sure. So psychosis then is the last condition. So psychosis could be the end result or the worst case scenario for depression and anxiety and bipolar, where the person actually from those conditions separates from reality. Or psychosis is a part of schizophrenia, that there's this reality separation. But you don't have to have schizophrenia to get psychosis. You can get it from other conditions. Psychosis contains these behaviors: delusions, hallucinations. Delusions means you believe things or have ideas that are not true in reality, which usually the delusions contain some element of paranoia or suspicion of people around you. Hallucinations are seeing, hearing, or feeling things that aren't there. An illusion is a distorted perception of stimuli. So I could see something, but the way it appears to me is not how it appears to other people. The actual, if I'm looking at the light, it might be different for me and distorted than it is for you, because my ability to take in information is changed. So you could get psychosis just from being in the hospital too long. It's a very common condition. where for patients, especially when they're in the ICU, because of all the noises and you can't tell if it's day or night, and over time that can lead to a separation with reality as well. But schizophrenia has those psychotic behaviors, hallucinations, delusions, paranoia, strange behaviors, and extreme behaviors. But those psychotic symptoms or altered reality type symptoms are considered positive symptoms, which is hard to, so it doesn't mean like, yay, I want those. It means it's above and beyond normal behavior. So most people don't have hallucinations, delusions, illusions, and extreme behavior. So you're adding to normal behavior. Negative symptoms of schizophrenia subtract from normal behavior. So these are the deterioration of hygiene and job and social performance, withdrawal from social interactions, detachment towards life. Those are the negative symptoms. The negative symptoms are harder to treat than the positive symptoms. So it's easier for me to find a medication to treat psychosis, to treat hallucinations, delusions, paranoid, extreme, irrational behavior. I can treat those. It's much harder to find medication or to help the patient with detachment, withdrawal, and deterioration, the negative symptoms. So there usually is a question about positive and negative symptoms of schizophrenia. So be sure that you understand that. So the first medications that were used in order to decrease or help people with psychosis and schizophrenia or phenylphthaleines. These are dopamine receptor antagonists. So we talked about dopamine receptor agonists. We talked about medications that act like dopamine when we talked about Parkinson's. So you can tell already that anyone who takes a medication that actually blocks dopamine might have Parkinson's-like symptoms, which is what this means. It actually stands for something called extrapyramidal symptoms, but essentially is Parkinson's-like because we're blocking dopamine. And this will control mania and the positive symptoms of schizophrenia, meaning the symptoms that add on behavior, the hallucinations, delusions, etc. But it doesn't help the negative symptoms very well. So it's hard to be compliant with these medications because you are left with the withdrawal and isolation symptoms. Other side effects include dizziness, drowsiness, and orthostatic hypotension. And with phenylphthaleines, there's a risk of something called neuroleptic malignant syndrome, which means the patient who's on this medication can develop a fever, and that fever can lead to headache and hypertension that gets very severe. And this neuroleptic malignant syndrome can be triggered by extreme temperatures. So we have to be careful with that. So if you have a patient who's on chlorpromazine and they complain of headaches and fever, you have to be sure that they're okay because they actually could be developing this neuroleptic malignant syndrome. So you have to check their blood pressure and see if they're okay on this medicine. So adverse effects of these antipsychotics are those Parkinson's-like symptoms. Dyskinesias that we talked about with some of the Parkinson's medications, they too can have the head bobbing, lip smacking, grimacing things. And dystonia means that you have this large muscle contraction. So sometimes the muscle contraction will take place in the neck and the face, and so the patient's head will be stuck in a certain position or their arm will be stuck in a certain position because a large muscle group will just tense up. Non-phenothiazines. So the idea was let's try to treat negative and positive symptoms of schizophrenia, and definitely treat psychotic symptoms without making them as sedated and less of those Parkinson's-like symptoms. So this medication, haloperidol, does that. There still is a risk of neuroleptic malignant syndrome, but it is not as common. It's more rare. But it's still present. So in order to try to get rid of neuroleptic malignant syndrome, there are other atypical antipsychotic medications that can be used just for psychosis or can be used for schizophrenia. Some of these are also used for bipolar, so it's possible to see many of these prescriptions not just for schizophrenia. I have seen lots of people prescribed aripiprazole, which is Abilify, or Seroquel, or Geodon, even briefly in the ICU just because of profound psychosis. The one that we'll talk about, which I've also seen prescribed in the hospital for psychosis, but can be used for other conditions that lead to psychosis, is Risperidone or Risperidone. And this is also a weak dopamine antagonist, so we still have the risk of fever and extrapyramidal symptoms, but we don't have to worry about neuroleptic malignant syndrome, which is good. So that's one of the great things about it, which is why it seems to be a little bit safer. And it's good at reducing both positive and negative behaviors of schizophrenia, so it does seem to work better, so that's also good. The issue with all the atypicals is weight gain and hyperglycemia, and it's a large amount of weight. You know, people can gain like 50 to 60 pounds in just a couple of months. So we have to be very careful with diet teaching. That's the most important thing with this medication. When they start it, to be sure that you have healthy diet practices before the medication is even started, because they will gain weight. So I have some correcting to do to be sure the right sheets are up and the right study guide is available. But that is the information that we need for the next exam. So we are done a bit early today. Does anyone have any questions?
So on the ATI, it's going to be the module, the neurological module, part 2 that's due?
Yes. That's correct. So before the next class, you have to do the part 2 in order to get into the exam. It looks like Hannah missed that. So you have to do the ATI Neuro Part 2. In order to take the exam. That's what's due. Nellie, did you have another question?
Yes, and I didn't double check, but you'll put up that other sheet that has the answers on it, as far as, I can't find it, the one that we did this morning, here it is, about the adrenergic and the cholinergic, all that kind of stuff.
Yes, I will put that correct one up. I will put the study guide they can use for the seizure medications up. And let me just look at that study guide before you actually print it, because I think I missed the migraine medications. I don't know. I'm broken today. I'm sorry, guys. So I want to be sure that everything's correct on there. So I will send an announcement when all the correct information is posted. Um, just so you know when it's safe to look. You're welcome. Any other questions?
Actually, I had one more. So, given that we kind of like switched around as far as like how we're taking our class, are you still going to be able to put recordings of your lectures up?
Yes, I can do that. I've been recording, so I'll put those up. Okay, guys. Well, have a good week. And next class, we'll have the next exam. Take care.